So for our final lecture in this session, Dr. Elizabeth Bettinelli will talk to you about bleeding disorders. Beth is an assistant professor of medicine in the Division of Hematology at the Brigham. And we'll start now. Beth?
Thanks very much, Nancy. All right, so there are my disclosures. All right, so good afternoon, everyone. Today I'm going to be speaking with you about bleeding disorders, and I'd like to start by having a very basic review of primary and secondary hemostasis. The cases that I have chosen for a presentation today actually illustrate abnormalities in the different stages of both primary or secondary hemostasis, all of which result in bleeding disorders. So let's start by understanding these two defined processes. So first thing that happens is that there's a vascular injury, and this results in loss of the endothelium, which are these cells here, and exposure to collagen. When that happens, you have the start of primary hemostasis. Platelets here in yellow, which are in circulation, see this area of denuded endothelium where the collagen is exposed, and they bind to that collagen via von Willebrand factor, which is shown here in these little red dots. When the platelet has adhered to the site of the vascular injury, it undergoes a shape change, and then it releases its granular content. Some of the things that are released include ADP and thromboxane, and those things can recruit other platelets to this area. And this is how a primary hemostatic plug is formed, and that's through a process of platelet aggregation. Next, we have secondary hemostasis. This depends on phospholipid complex expression at the site of the platelets, but also release of tissue factor from the endothelial cells. The tissue factor initiates the coagulation cascade, all for the process of thrombin activation, which then results in fibrin polymerization. Now, in part D, once you have that nice thrombus that's formed there to stop the bleeding, we need to limit that. So we need some antithrombotic events. And this is under the regulation of TPA, which induces fibrinolysis, and thrombomodulin, which blocks the coagulation cascade. So now I'm going to jump into 4 cases, which basically take us through disorders that impact the various stages of this coagulation cascade. I'll try to advance. If not, thank you. So the first case, this is a 32-year-old woman visiting us from another state. She's pregnant with her first child, visiting friends, and unexpectedly goes into labor. She tells the covering team that she has von Willebrand's disease, and she hadn't had a chance to talk to her doctor about this, but she wants to make sure that she can get an epidural. You are asked to see her and provide advice regarding the advisability of an epidural and whether or not she needs any treatment for von Willebrand's disease in pregnancy now. Next slide. Let's start out by looking at some laboratory values for her. Essentially, everything is within normal range. Her chemistries, including her BUN, creatinine, and glucose, are normal. Her CBC shows a typical hematocrit that which you would see at this stage of pregnancy with a hematocrit of 35, a white count that's normal, a platelet count that's in the normal range. The differential is reported as being normal. You order some coagulation parameters. Her PT is 11.5 with an INR of 1.1. PTT is 28 seconds with normal being less than 35. So all of this is pretty normal and is not consistent with having a bleeding disorder. Next slide. You go and talk with her a bit so you can understand more about her condition. She tells you that she has had the occasional nosebleed since she was a child and that she had menorrhagia. She also bled a lot when she had her wisdom teeth extracted. She said she was diagnosed with von Willebrand disease and usually gets treated with intravenous or intranasal administration of DDAVP for bleeding or before any surgical procedures. Her mom and her sister have similar symptoms and respond to the same medication regimen. To get more information, you try to reach out to her primary hematologist, but you're unable at this time. Next slide. So let's step back and learn a little bit more about von Willebrand disease. It results from reduced quantities or abnormal forms, so either qualitative or quantitative forms of subendothelial factor VIII and von Willebrand factor complex. So this results in decreased adherence of the platelets at the site of vascular injury. And here you can see these platelets are trying to stick to the area where there's the endothelial injury. This inadequate platelet plug results in excessive bleeding and bleeding times and blood loss. These patients may experience a number of different types of bleeding under challenges, but also can have spontaneous mucosal bleeding, and they usually demonstrate an autosomal dominant inheritance pattern. Next slide. Remember that there are a number of coagulation abnormalities and differences that happen in pregnancy, and this results in both an increased risk of bleeding as well as an increased risk of clotting. So some of the factors that increase in pregnancy include fibrinogen, von Willebrand factor, and a number of different coagulation factors, including 8, 7, 10, 9, and 12. But concomitantly, you also have a decrease in things like protein S, acquired resistance to activated protein C. These things lead to an increased risk of thrombosis. You can have fibrinolytic problems and a decreased platelet count, both of which can put patients at risk of bleeding. So for von Willebrand disease, the most common inherited hemostatic disorder, it has a prevalence about 1%. And it presents with mucocutaneous bleeding, such as epistaxis, easy bruising, GI bleeding, bleeding in a post-op setting or bleeding during surgery, and bleeding during dental procedures. And it is important to take a history to establish any of these types of patterns of bleeding. It could be considered a women's health issue, as 75% of women with von Willebrand disease have menorrhagia, and it's often diagnosed after the first menstrual period or at the time of delivery with postpartum hemorrhage. Where we start with this is with a laboratory evaluation with something called a von Willebrand panel. We first usually do a PTT, which is usually prolonged in this setting. We then look for changes in this von Willebrand panel, which includes a factor VIII, which remember is a cofactor for the von Willebrand factor itself, von Willebrand factor antigen, and then a functionality assay, which is the risdiplam cofactor activity assay. You also want to look at the high molecular weight forms of von Willebrand factor, and you do that with a multimer gel electrophoresis. So mild types of von Willebrand factor can be very difficult to diagnose because it can be in fact affected by many things. Patients with type O blood actually have a 25% lower level of von Willebrand factor at baseline. Estrogen, inflammation, stress, all of these factors can actually increase von Willebrand factor, and smoking can also increase the von Willebrand factor levels. Classification of von Willebrand disease can often be confusing. You have two different extremes. Type 1, which actually is the most common. It is autosomal dominant, and it's a quantitative decrease in von Willebrand factor with a concordant decrease in functionality. And this occurs in 70 to 80% of von Willebrand cases. Type 3 is homozygous recessive, and it's almost no detectable von Willebrand disease. So as you can see, these levels would be at two different extremes, and type 3 is actually very rare. Type 2 is where people usually get confused. Type 2 is a qualitative abnormality. So they may have normal or slightly low levels, but what they have actually doesn't function properly. So it's a function defect. You have type A that has decreased large molecular weight multimers, and this occurs in 10 to 15% of von Willebrand disease. Type B, which is actually a gain of function mutation. So there's increased binding to the GP1B on the platelet, because remember, the platelet binds to collagen via von Willebrand. So patients with type B often present with a thrombocytopenia because of this increased binding. Type 2M is another loss of function mutation. Here, though, it's decreased binding to GP1B on the platelet surface. And type 2N is a loss of function mutation, but this time there's decreased factor VIII binding. So just from looking, you can see if a patient has type 2B, if they have an associated thrombocytopenia, we start to think about that. And if their factor VIII level is incredibly low, we think about we think about 2N. For distinguishing between 2A and 2M, you actually do need to look at the multimers on the gel. All right, now moving on to the next slide. So now a little bit about what happens to von Willebrand disease in pregnancy. Antigen levels increase with the increased estrogen on board during pregnancy, but the function doesn't change. So if a person has type 2 with the functionality issues, even though their levels may increase, they still will have the functionality issues. So there's an increased risk of postpartum hemorrhage in patients with von Willebrand disease. Levels usually return to baseline as the estrogen drops over 7 to 21 days in the postpartum period. And that's really when patients are at risk of bleeding. 20 to 25% of patients with von Willebrand disease will have delayed postpartum hemorrhage. And the mean onset can be around 15 days or so. So what happens next with our patient? Well, at 3 a.m., the patient delivers a 7-pound, 4-ounce healthy baby boy without any bleeding issues. In the morning, you're finally able to reach the primary hematologist, and you learn that indeed this patient does have type 1 von Willebrand disease. Labs prior to pregnancy were mildly low, with a von Willebrand factor antigen of 30, activin of 35%, and factor VIII level of 45%. The patient had actually seen her obstetrician a few weeks before this trip, and her values 2 weeks prior to this delivery, she had an antigen of 105, activity of 120, and factor VIII activity of 150. So as you can see, with estrogen, her levels have increased. 48 hours after delivery, you are making rounds at the hospital, but you're paged by the obstetrician who's covering this patient because the patient has developed uterine hemorrhage. So what should the guidelines be for how we should manage these patients? Well, NHLBI has set out that we should set a ristocetin of cofactor activity and a factor VIII levels that are at least 50 international units per deciliter, and that should be achieved before delivery and maintained for at least 3 to 5 days around the time of delivery, after delivery in that postpartum period. So what really should happen with these patients is that we should be diligent at the time of delivery to check their levels. We have a number of different options for treating patients. We can use desmopressin or DDAVP. What this does is releases the stores of von Willebrand factor from the Weibel-Palade bodies in the endothelial cells. But remember, if they have a type 2 and they have a qualitative problem, the von Willebrand factor that's released will still have that qualitative deficiency. The onset of action of DDAVP is within 30 minutes, and you need to watch for tachyphylaxis with repeated dosing. Side effects include headache, hypertension, flushing, nausea, vomiting, hyponatremia, which can result in seizures, and uterine contractions. So really, we only want to give a couple of doses of this if we need to, and you would consider doing a pre-procedure DDAVP challenge to make sure that the patient gets an adequate response before initiating this therapy if time allows. Other options include von Willebrand containing concentrates. This is plasma-derived pathogen inactivated forms. And you can dose via factor VIII levels or von Willebrand antigen levels. UMAP and alphanate are two of the drugs that are often used. In very dire circumstances where you don't have any of these products, cryoprecipitate can be considered as a last resort. But remember, it's pooled from over 10 donors. All right, now that we've talked about a problem with von Willebrand factor, let's now move on to a second case. This is a 23-year-old woman who presents with bleeding after a wisdom tooth removal. The patient was referred to the ED from the dental clinic after the dentist just could not control the bleeding. The patient has no history of epistaxis or gingival bleeding, but does report that at the onset of her menses, her period was so heavy that she had to regulate menses with oral contraceptives at the age of 12. She has no history of any other surgical procedures, so you don't have any other challenges. She's never had any other tooth extractions or any other bleeds. You find out a little bit more about her family history. Her mom has von Willebrand disease, she tells you, and there's no one else in the family with any bleeding history. Great. All right, so we start off with getting some labs on this patient who is bleeding in the ER. She has a white count of 8.6, hematocrit of 38, a platelet count of 235. The appearance of the platelets, you're told on the smear, is normal. PT of 1.1, PTT 32, fibrinogen's normal. You get a von Willebrand panel, that's also normal. So you decide to order some platelet aggregation studies, and you're told that they're abnormal. When you look at the platelet aggregation studies, you see that there is absent aggregation in response to multiple agonists, including ADP, thrombin, collagen, and arachidonic acid. But you have normal aggregation in response to ristocetin. Exactly how are platelet aggregation studies done? Usually it's done using light transmission aggregometry using something called a chronolog type instrument. There are different agonists that we use to stimulate the platelets, including ADP, arachidonic acid, collagen, epinephrine, and ristocetin. Some institutions also offer an ATP secretion assay. This is really helpful for storage pool disorders. This is a luciferase-based assay. And again, ADP, arachidonic acid, collagen, epinephrine, ristocetin, but now with the addition of thrombin, the most potent stimulant of platelets, are used for the secretion assay. Numerous things can impact platelet aggregation. You need to make sure that the anticoagulant that's used for the tube of blood itself is the proper anticoagulant. The platelet count can impact this. At our institution, we usually aim for a platelet count of 150. The platelet size distribution, so extremely large platelets may impact this. Platelets are more activated in the morning, so the time of day, and relation to meals. So if a patient has had an excessively fatty meal prior to having platelet aggregation, their blood may be a little bit cloudier and yellow, and this can impact the results of the aggregation testing. So basically, what happens for platelet aggregation is you take a test tube of blood and you use centrifugation to collect the platelet-rich plasma. If you take that platelet-rich plasma and just were to turn it about in the tube itself, you'd see like a little tornado cloud, and that's the platelets. It's very cloudy in appearance. When you add the agonist, what happens is those platelets start to clump together, they drop to the bottom, and if you now shine a light through this test tube in comparison to the amount of light that could pass through when it was cloudy at the beginning, now this aggregated blood with the platelets having dropped to the bottom, more light goes through. And basically all we're doing is measuring the passage of light through the test tube, and you get the appearance of these tracings. When the platelets are hit with a very weak agonist, such as ADP or epinephrine, you actually have the opportunity to watch for the primary wave, which is that initial shape change that the platelets undergo. When they're hit with a strong agonist, such as collagen or thrombin, it goes straight to secondary wave, straight to aggregation, and you don't have the opportunity to see that primary wave. So basically, we are just looking for the formation of this secondary wave, which is the aggregation of the platelets. Now, a number of disorders can occur that can impact the ability of platelets to aggregate. You can have problems, again, with von Willebrand factor, but you can also have, and these are the two main ones that we usually need to know for things like boards. You can have Glanzmann's thrombasthenia, which is a problem with the fibrinogen receptor, the receptor on the platelet called 2B3A, or Bernard-Soulier, which is a problem with the GP1B receptor. There's other abnormalities as well, which can impact ADP as well. Let's talk a little bit about Glanzmann's thrombasthenia. That's what this patient actually had in the end. The platelet count and morphology is always normal in Glanzmann's. The bleeding time in the old days, you may have a patient who, we don't do bleeding times anymore, but some of your older patients may actually report to you that they had a bleeding time when they were younger. And basically they may even have marks from when the scalpel was used on their wrist. And this can be a prolonged test. The hallmark of the disease is severely reduced or absent platelet aggregation in response to multiple agonists, ADP, thrombin, collagen, but normal response to ristocetin. And that's because ristocetin works through the 1B receptor, and the 1B is normal on these patients. It's 2B3A on the platelet surface that's abnormal. You would confirm your diagnosis once you see these abnormal aggregation patterns by using flow cytometry to look for expression of CD41, which is 2B, or CD61, which is 3A on the platelet surface. How do we manage patients with platelet disorders? Usually we give platelet transfusions, but we have to be very careful with that because over time, the more exposed a patient is to platelet transfusions, the more likely they are to develop antibodies. And then when the patient actually has a major bleed, they're not responsive to platelets and we have few options. In some cases, for small, minor bleeding, such as wisdom teeth bleeding, you can try to use DDAVP and Amicar, which is an antifibrinolytic, to support the hemostatic process. In rare cases where you can't control the bleeding or the patient is not able to receive platelets because they've developed antibodies, you can actually use activated 7A. This patient receives a platelet transfusion and she does improve after she receives the platelets and her bleeding stops. I've cared for this patient for many years. She's received 3 platelet transfusions in her life. She's now developed antibodies, which limit our options were she to have a major surgical procedure or a spontaneous bleeding episode. So in that case, if that were to happen, we would consider the use of activated 7. Moving on now to the third case. This is a 75-year-old female who comes in for pre-op clearance for cardiac surgery. She's referred to the clinic for a prolonged PTT. She's not seen a physician in over 40 years, and she has absolutely no bleeding history. For the prolonged PTT, you get some laboratory testing for factor levels. Factor 13 screen is normal. Her factor 8 level is 102. Her factor 9 is 89, but her factor 11 level is 22. So this patient has factor 11 deficiency. So we've now moved on to secondary hemostasis, and this patient has a problem with the coagulation cascade. Factor 11 deficiency is a rare bleeding disorder. It's inherited as autosomal recessive, and it presents with a prolonged PTT. It's characterized by a variable bleeding history. As you can see, this patient has got through 75 years of life and never had a bleeding problem. I have other patients in the clinic who are younger, about to have a baby, and they have had multiple bleeding episodes, and yet their factor level may be actually higher than this patient who has never had a bleed. So the incidence is 1 in 450 in the Ashkenazi Jewish population and 1 in 1,000,000 in the non-Jewish population. Just to remind you, factor 11 is found up here in the intrinsic pathway, and this all leads down to factor 10 activation and thrombin formation. Factor 11 deficiency, the bleeding manifestations do not correlate with the factor 11 levels. So you have to not only look at what the level is, but you need to also look at what's the patient's bleeding history. Most bleeding episodes in patients with severe deficiency are actually injury related. Spontaneous bleeding occurs very rarely. It may be associated with bruising, epistaxis, menorrhagia, GI-GU bleeding. Babies may present with umbilical stump bleeding. You could have bleeding after a surgery or a trauma, dental procedures, pregnancy, or even at circumcision. Up to 33% of patients with severe deficiency will develop inhibitors over time after the use of replacement therapy. How do we treat factor 11 deficiency? Fresh frozen plasma in the US is our main way. Usually we use the formula of 10 to 20 mils of FFP per kilogram, then 5 to 10 mils per kilogram every 24 hours as necessary. You can imagine that this can get excessive. If the level is very low, you're not going to be able to correct it back to a normal level. And this can be presenting with a lot of volume, especially in someone who has a cardiac history. Antifibrinolytic therapy has been used in women with factor 11 deficiency who are experiencing menorrhagia. That way you can avoid trying to replace them with FFP. Patients with inhibitors have been treated successfully with prothrombin complex concentrates and recombinant activated factor 7. In Europe, there are factor 11 concentrates available, but because of thromboembolic complications, the US has been slow to actually adopt those products. Moving on to the last case. So this is a 44-year-old female who comes into clinic for a bleeding evaluation prior to a planned knee surgery. She has a history of heavy menses and bleeding with wisdom tooth extraction and during childbirth. Her mother also has had a history of bleeding with procedures. You obtain some labs. She has a white count of 6.7, hematocrit of 38.7, platelet count in the 200s, PT of 18 with an INR of 1.5 and a PTT of 37.9. So she has abnormal coagulation parameters. You get a fibrinogen and it's low at 67. So we've moved on from von Willebrand factor, platelets, to the secondary hemostasis with coagulation abnormalities. And now we're in that final stage of secondary hemostasis when you would have problems with fibrinogen. So what types of fibrinogen abnormalities can occur? You can have quantitative problems such as afibrinogenemia, absence of circulating fibrinogen, or hypofibrinogenemia, reduced levels of circulating fibrinogen. You can have qualitative or function problems, dysfibrinogenemia, dysfunctional fibrinogen, or hypodysfibrinogenemia, which has both reduced levels and also dysfunction. You could have acquired problems with fibrinogen. As we know, patients with liver disease may have a hypofibrinogenemia. They could also have dysfibrinogenemia due to increased sialic acid residues that results in delayed fibrin aggregation. DIC has increased levels of fibrin degradation, and even HLH can have a hypofibrinogenemia due to liver disease. So you need to rule out the acquired causes of fibrinogen abnormalities. Diagnostic approach is to start, of course, with a personal and family history of bleeding, and then to get some coagulation testing. PTT is where to start, but then you could actually get something called a thrombin time, which is a screening test to assess for fibrin formation from fibrinogen in the plasma. Thrombin's job is, of course, to cleave fibrinogen, and it releases fibrinopeptide A and B. A thrombin time can be prolonged if heparin is on board. You can also order a fibrinogen level, a functional fibrinogen, as well as a fibrinogen antigen, and then something called a reptilase time, which is very similar to a thrombin time. It's used to detect deficiency or abnormalities in fibrinogen. Reptilase is an enzyme found in the snake venom that behaves very similar to thrombin. It splits the fibrinogen into fibrinopeptide A, but not B, and again leads to fibrin polymerization. Unlike thrombin, however, reptilase is not inhibited by heparin. So it can be very helpful for distinguishing a patient that has heparin on board or if they have a true fibrinogen abnormality. You could also get a mixing study. It corrects with afibrinogenemia because you are adding fibrinogen in with the plasma that you're adding in the mixing study, or hypofibrinogenemia, but does not in a dysfunctional problem. So if the fibrinogen doesn't function properly, it's not going to be corrected in the mixing study. So that gives you a sense of what type of tests you can start out with if you think your patient has a fibrinogen deficiency. And you can use these tests to try to determine if someone has afibrinogenemia, hypofibrinogenemia, or dysfibrinogenemia. And basically, that can be very helpful because we treat these in different ways. So in this case, the patient had a prolonged thrombin time at 32.5, a reptilase time, which was prolonged at 100, and a fibrinogen antigen, which was also low at 63. So how do we manage these patients? We usually only need to manage them when they have episodes of acute bleeding. You need to increase their fibrinogen level to 150 to 200, depending on the type of procedure they're having. And you can do that using fibrinogen concentrates or sometimes plasma products such as cryo or fresh frozen plasma. Prophylaxis is not usually required unless they have afibrinogenemia, so no fibrinogen, or severe hypofibrinogenemia. So in summary, in bleeding disorders, you must think about both primary and secondary hemostasis to understand the etiology. I've taken you through some cases of primary hemostatic abnormalities, including platelet disorders and von Willebrand problems, and secondary, where we had factor 11 deficiency as a representation of a coagulation factor deficiency, and then fibrinogen or fibrinolytic problems in the case of a hypofibrinogenemia patient. History is key for both diagnosis as well as management. So with that, let's move on to some audience response questions in the form of board review questions. So let's start. Question 1, you are asked to see a 37-year-old woman with a history of von Willebrand disease for consultation. She asks, is it safe for me to have elective knee surgery? The patient has never had surgery before. She had frequent epistaxis as a child and heavy menses. You get a family history, and the mom has a history of von Willebrand disease, but died young due to trauma. She tells you that she has 5 uncles. Her dad has no bleeding, but she has these 5 uncles, one of which does have a bleeding disorder. So you get some baseline von Willebrand levels. Her factor 8 level is low at 27. Her antigen is 89. Her ristocetin cofactor is 75, and her PTT is 46. Given the normal antigen and the ristocetin activity that's normal, you're asked, what type of von Willebrand disease does this patient actually have? So you have some options. A, type 1, and you should treat this patient with DDAVP prior to her knee surgery. B, does she have von Willebrand disease? She does not have von Willebrand disease because her von Willebrand antigen and her ristocetin are normal. Or C, you need more information. She could have a type 2N or actually be a symptomatic hemophilia A carrier. So I'm told I need to wait a little bit for voting. All right. So there's still some people, I think, who are voting there. See the numbers going up. It's looking, though, like the majority is number C, which is you need more information. She could have type 2N or be a hemophilia carrier. All right. So that's very important to distinguish 2N from hemophilia A carrier, especially in this woman. 2N should be considered in autosomal recessive inheritance with a disproportionately low factor 8 levels compared to the von Willebrand factor levels. In this case, in order to prove if the person had type 2N, a test could be done called a factor 8 von Willebrand factor binding assay, and that can actually help you to distinguish. Usually these patients have problems in the von Willebrand factor at the amino terminus where the factor 8 actually binds, and that's R854Q. That's at the amino terminus, and that's where they most likely have a problem. So distinguishing between someone who's a hemophilia carrier who just has a low 8 but normal von Willebrand factor versus someone who's a true factor von Willebrand 2N can often be complicated. How do you treat it? Now, that does depend on what they have. A hemophilia A carrier will have low production of factor 8, normal von Willebrand. You can actually treat them with recombinant factor 8 and maintain levels in the post-op period, whereas a von Willebrand type 2N can have normal production but abnormal binding of factor 8, endogenous factor. Von Willebrand factor does not bind to it. You want to treat them with UMAP or another von Willebrand concentrate, and you wanted to also monitor levels in the post-op period. So that's a little bit about how to distinguish 2N from a hemophilia A carrier. And so C was the correct answer. Moving on to, whoops, that's not supposed to be there. Moving on to our second question. This is a 38-year-old female seen in the ER for bleeding gums after a dental procedure. She tells you that she has essential thrombocytosis, or ET, and takes daily hydroxyurea and an aspirin. A von Willebrand CBC is drawn and her platelet count is 1.6 million. The ER team consults you and asks, why is this patient bleeding? She has so many platelets. So you have a number of answers. Again, audience response. A, the patient is on aspirin and is bleeding due to the antiplatelet effects. B, the patient has developed an acquired von Willebrand disease in the setting of this high platelet count. Or C, this is a laboratory abnormality and the platelet count should be repeated because clearly she couldn't have such high platelets. So the voting now begins. All right, still some votes coming in there, I see, but it looks like the majority are saying B, the patient has developed acquired von Willebrand disease. Great. So this patient has developed acquired von Willebrand disease in the setting of thrombocytosis. Basically, this large number of platelets has caused a lot of binding with von Willebrand protein. So you can diagnose this by confirmation via von Willebrand panel, which will demonstrate low risdipine cofactor activity, normal antigen levels, and of course, in these patients, that's why we need to be very, very careful when the platelet count gets over 1 million. We should consider that this could occur, and we should think twice about using aspirin when the platelet count is this high. So the answer for the case 2 is correct. B, this patient has developed an acquired von Willebrand disease. And that is the end of my talk. Pretty much on time. So
perfect. Great. So we have a few questions. So on case 1, did you tell the doctors that it was safe to give an epidural, which was the main question of the consult?
Right. Yes, that patient did have an epidural. Yes, because the PTT was normal, we assumed that the level was at least 50%.
Great. Can you use DVT prophylaxis or oral anticoagulation in a patient with von Willebrand disease who was admitted to the hospital for general medical condition or AFib?
Yeah, so you can. You just have to be really careful. I think that question depends on what type they have, if they're going to have any bleeding, which depends on what they're admitted for. So you just have to be very careful with them. But I would, consider doing some very low dose things. If you're undergoing a surgery that's going to put them at even more risk of bleeding, then obviously you don't want to be giving them any sort of anticoagulation.
And when do you?
Yeah, encourage walking, encourage ambulation.
When do you choose DDAVP versus von Willebrand factor concentrate to treat von Willebrand disease?
Yes. Okay. So in most patients who have type 1, you can really just use DDAVP. But I usually would suggest, especially if you're trying to prepare a patient for a major surgery, I would suggest that you do a DDAVP challenge. Make sure that their numbers are well above 50 for any sort of a surgical procedure. And so how that is done is that you basically give them the dose of DDAVP, you do a pre and 30 minutes post von Willebrand panel, and you look to make sure that the levels have increased nicely. In a patient that's going to be that has type 2, most likely you're going to need multiple doses, or you're not going to get enough of a response from DDAVP alone, or they have a type 2B, and you wouldn't want to give them DDAVP because then they would probably develop more and more thrombocytopenia, which would put them at increased risk of bleeding from two sides of things. You would want to use UMAPE or another factor replacement agent. And in those cases, also that have type 1 we usually will go to UMAP if they're having a very prolonged surgery that you're going to need control of hemostasis for many days, and you're going to want to use repetitive dosing. Because remember that DDAVP can cause tachyphylaxis, can cause seizures with hyponatremia, and so really we just want to give that once or twice. If we think we're going to need to have hemostasis for 72 hours or a week or something, control over hemostasis for a major surgery, even a patient with type 1, we may consider the use of UMAP in those patients.
Great. So apropos of your recommending walking, how effective is ambulation for DVT prophylaxis?
Effective. I don't have numbers, but I think that that's the main thing that we can tell our patients to do when we're worried about them and we don't want to be using anticoagulation.
Okay. And I have a question. Why do some warfarin anticoagulation patients exhibit severe PTT prolongation?
This probably has to do with their metabolism of the drug. And the fact that in some cases they do develop that prolonged PTT, and it isn't. You see it more likely when they're at the higher ends of the therapeutic range, or if they're really therapeutic, or like their INR is 4 or above. Sometimes you see it, but it probably has to do with their metabolism of the drug.